to figure out where cholera came from. And as the slide says, the population, the general notion was that cholera came from bad air that came off of rotting matter, organic matter. So they knew it was coming from somewhere, but they thought it was coming that way. It was in the air, it was atmospheric. Okay, so the person who has been involved with looking at this approach is John Snow. He's the father of modern epidemiology because he actually went back and traced where it came from and found that it probably was coming from contaminated water sources, not from air over rotting matter, but in the water itself. So he did the epidemiologic approach, which is, or the public health approach, which is first of all define what is the problem. So what he did, this is a map of London, and you can see that each of these little dots is where a case of cholera, a person lived who had the cholera. So you can see that there's a lot of it all up and down these streets, and a lot of it on Broad Street in London. He was assisted by a pastor, a clergyman, who went door to door, and they were asking everybody about, was there cholera here, was it not, and asking lots of questions about where they'd been, what they did, to try to put together. So that's a case where you're looking at community stakeholders working with the individual who was studying it. So it took more than just one person to figure this out, definitely. Okay, so you can see the cluster was more common on this particular street. So then after we had done what is the problem, then your next question is risk factor identification, which really is what is the cause. So now that they know what the problem is and where it was, what was actually making that come about? You can see this little map here. Because he felt like water was one of the sources that was being transmitted through, they went and mapped out the site of all the public pumping sites for water, the water wells in the city. And you can see that there's a black marked, big black square for all of those, and then all of these are the places where the cholera took over and actually caused deaths. Okay. So they could see that there was a lot of cholera clustering around certain pumps, in particular this one on Broad Street. So they began to identify sources. Okay, so then they felt like, well, that may be a good link. We've got deaths here, the deaths are around the pumps, so we're going to look at what we can do. So the intervention got to what would work. Well, obviously stopping exposure to contaminated water was a good deal on a large scale, but also trying to keep it from spreading within the area. So they had to think about ways to actually keep the water from being used by people in the sites where the contamination was. And of course, this is before they know everything about microbiology, and they're just looking at big issues that they can track down, and then they have to kind of imagine how transmissions take place. So they eventually were able to convince the government, the British government, the source of cholera was water contaminated with sewage. And what they did initially was they took the handles off the pumps. So that kept people from using that pump as a water supply. So I mean, it's pretty aggressive. We're just going to stop them from using this well by pulling the handle off. But they also eventually got in place public policies. But they had to work with the government to get that in place, and that's not an easy thing. Because back in that day, when people weren't really quite sure about infectious diseases and processes anyway, convincing a government not to do something, they pretty much had to convince them not to do it just based on their findings, where the cases were and what the links were. But they eventually were able to pull that off, and so they put in place a policy. So, quick review. Each public health core science helps us. It's really protect and promote public health by providing public health practitioners with the answers they need. So your public health is protecting public health, but also promoting it. Okay, here's these elements again of the public health approach. What is the problem? What is the science that does that? It's going to be, think. What's the problem is surveillance. What is the cause? Probably risk factor identification. What works?
Intervention,
evaluation, and how do you do it? Implementation. Okay, so there you go for all of those. Okay, let's look at the core functions and essential services of public health. Okay, there's 3 core functions of public health, these broadly, and we've already kind of talked about those just straight out. First one is assessment. That's just systematically collecting, analyzing, and making available information on healthy communities. Policy development promotes the use of a scientific knowledge base in policy decision making. And then finally, assurance is just setting up a method to be sure that things are being done as they should. So I mean, it really just comes down to assessment is just knowing what needs to be done, policy development, how do you do it, and then assurance is can you validate that you do what you say you're going to do. Okay, let's look at the 10 essential public health services, and they're kind of based around the core functions. You see you get assessment, policy development, and assurance. Within assessment, 2 services are monitoring health and diagnosing and investigating. You can kind of use it like you can use tobacco as a way to kind of look at each one of these. Monitoring health, if you're looking at tobacco, it might be what are the usage rates in counties and states around the country. That can give you a pattern. Diagnose and investigate what are the risk factors that lead to that smoking, what's that smoking doing to people. So that will be an area. Then you move into the area of policy development. Inform, educate, and empower. That might be putting warnings on cigarette packages because that happened back in the 60s. And we do it for a lot of things right now. Informing and educating, that could be classroom instruction. It could be the health class, you know, that state mandates that you do that in the curriculum. Mobilizing community partnerships. That might be working with groups that have specific populations that they advocate. Maybe a Hispanic group talks about smoking within that population and they take it down to their grassroots level. Or an African American group that has linkages into the churches and they talk about it within that arena. So that's getting community partnerships. Developing policies, that's legislative process, and enforcing the laws, you know, that could be also law enforcement. You know, no smoking policies in institutions. I mean, is it a civil crime? I mean, some of these things actually do rise to the level of breaking the law. You know, you can't sell cigarettes to people of a certain age. Okay, well, why is that? I mean, if you got money, why can't you have it? Well, there's limits. Can anybody go out and buy beer? Okay, there's laws about that, and those laws have as much to do with public safety as they do with public health. So we're just kind of so used to this stuff around that we don't think about it, but there will be, all of those things didn't exist for all time. They came about as problems were identified, risk factors came about, and then you start having partnerships among people, and then we go ahead and turn things into law. Well, some of those things are just guidance, but some of those things actually are law. So if you go by, you can be arrested or charged with a crime. If you're a store that sells things or gives cigarettes to minors, then that's an offense too. Okay, using food stamps to, you know, buy a loaf of bread, give a big $1 food stamp, take it back as cash, and then sell beer to that person. Okay, that's how that kind of works in the world right now anyway, is beating the system to do bad things, so that is, of course, a crime. Okay, link to or provide care. This could be the health system. If you've identified people who are at risk for something or have something, then you find ways to get them the help they need. That's why we have health departments. Sometimes they give vaccinations for things. There have been programs where smoking cessation aids have been given, like gum, you know, to help people stop smoking. Assure a competent workforce. Be sure that healthcare providers understand what the public health issue is and what is being done to support that or back it up, and then we do that blow by blow, patient by patient as we see them. Or put signs up in your waiting area. Or the big thing now is to have TV monitors kind of rolling through a scroll of topics, or to have touch screens where you can get health information while you're in the waiting room. So just touch things you're interested in. Those are kind of useful. And they actually fit the current generation, which is very used to video stuff and listening and watching. the population now is much more interested in learning by seeing and hearing a moving image. Back in the day, people might read signs. Now they like to look at stuff. Social media is big. If you wanted to really get the word out on something of a health issue, just get it out there and then it just booms, all over the place. Then evaluate and then research. And this is, again, your epidemiologists, statisticians help us figure these things out. So you can see how all of these different services fit under those three core functions of public health. And then core functions at government levels. When you're looking at public health, there's not a single entity that covers it all. It really is a discipline by nature that has to develop partnerships at various levels of government, from the federal government to the state government to local units, and then partnering with education, social groups. There's a lot of different ways to do it. So public health might be the group that is most active at understanding and using networks, because it takes all that network effect to pull things off. You can make a law against something, but if you don't really have a way to educate, communicate, and get public buy-in so that the social pressures, go with it, it's hard to make things like that work. So I think public health folks just know lots of ways to get information out there and how to work the system to communicate and educate. But if you look at the three core functions of public health: assessment, policy, development, and assurance, look how that operates on the different levels. Federal government, national tobacco public health surveillance, they look at that, collect all the data. Policy, smoking bans on commercial flights, that came out of the federal government, the FAA, you're not going to do this on planes, thank goodness. And then federal grants for anti-smoking research might be another way to help assure that things are done right. On a state level, the assessment might move down to monitoring state tobacco use. Oklahoma does it. I think every state does it. Policy development, increased tobacco tax. That's been a big thing in Oklahoma right now. The state budget did not balance this year, and it's been a mess ever since, because they were going to raise the price on cigarettes by like $1.50 a pack or something like that. And they passed it, but the state court system said it was against the law the way they had done it. So they pulled it back, and when they pulled it back, that left this multi-million-dollar gap in the budget. And they are still trying to figure out how to make that work even right now. So look, states use taxations. They try to make you pay more for things that are not good for you with the notion of discouraging you. I had a lot of patients. Some people will not even respond to that. I've had patients who really didn't spend their money wisely. In my view, they couldn't afford to buy medications or even pay co-payments on Medicaid medications, but they had multiple packs of cigarettes in their pocket. Well, the co-payments were well covered by the cost of the cigarette packages, but the choice was, I'd rather have my cigarettes than have my medicine and then complain, you should give me the medicine for free. Well, it's just kind of like there's a mixed message in there somewhere. But state governments do use taxes, local governments do the same thing. And then an assurance method at a state level might be funding for a campaign through Proposition 99, different laws that come in place. And then locally, what did they do for assessment? Report on local tobacco use, yes. Policy development might be county laws prohibiting smoking in bars, so it gets down to a very local level. And then assurance might be resources to help smokers quit in multiple languages. So sometimes our public health efforts fall apart because we're putting it all out there in English. But you need Asian, you need Hispanic, you need culturally relevant materials that fit that population. So you really have to work with people who understand that, because it's so hard for us to know all the ways to create materials or even to communicate the message, within the various populations. Okay. Which of the following is not a core function of public health? Okay, we talked about assurance, we talked about assessment, we talked about policy development, and we talked about authority. No. And authority really is not a core function of public health. Now, the entities that work with public health, like state, local, and the federal government, can put things in place. They can make an authority. But public health by itself doesn't have authority. It has to get authority by working with other partners who do that. And of course, you know, this is a frustrating part of public health, but it will also be a frustrating part of your job as an individual healthcare provider is, what authority do you have to make public health initiatives work? Well, you don't have it either. Your greatest ability is to be compelling in your presentation and your concern for an individual patient. You don't really want to get into turning folks into the law. That's really not what that relationship is in the room. And so you can talk to people and help them make choices, or maybe even think more about the choices they do make as you develop your relationship with that person over time. Okay, the essential health services of monitoring health and diagnosing and investigating disease relate to which core public health function? This one will be pretty easy. What do you think? Just by reading. B, yep. Okay, let's look at the stakeholder roles in public health. I've already been talking about stakeholders, but there are actually quite a few. Look at this. To ensure that the population stays healthy, there are a wide number of groups, you know, within the public health system. Partnership group. You've got community is important, just local people. What do they want for their people? Clinical care delivery system. You as a healthcare provider will be part of that network that communicates with individual patients one by one. Employers and businesses can be partners in public health. Like, you know, here they've got wellness programs, and there's some places that do wellness programs for reduced fees for services. So that can be part of it. The media, that's huge. That's a big partner. And I think most of our knowledge right now on public health issues probably comes from the media. TV, newspaper, social media, that's where you see things. And if something comes out that's kind of controversial, it gets debated and discussed on social media. So it's kind of interesting how stuff works. It used to be before social media, people wrote letters to newspapers and they respond to each other back and forth. It's kind of slow moving. Maybe you get a program on TV, and some of the old programs that were kind of useful for public debate were things like 60 Minutes. I mean, there was nothing else out there, really. You'd have 60 Minutes would bring up a controversial topic, and then have all the different sides talking about it. So if you watch that, you kind of got a feel for how does the world look at this. And now with the social media, if some law is passed about a health-related issue that's a public health issue, it can be all over the United States in less than 24 hours with all the views out there. It's almost too much information, too fast to actually take it all in. It's kind of crazy. But media is big now, probably the biggest. Academia is a partner. They develop people, train people. We're teaching about public health, you know, to make it part of your understanding as a healthcare provider. And then government public health infrastructure. What is that? That is local county health departments that are batched together to report to the state health department. The state health departments kind of work together as in a coalition of public health departments across the nation. So, you know, CDC is a little group, you know, they have a certain part of public health as well. So that's a government entity. So all these little things fit together to become part of the public health matrix. You know, we aren't anywhere near as controlling as some countries. Europe, you know, just look at Europe as an example. Their healthcare tends to be socialized medicine so that it's a right for all the citizens, so the country handles public health for everybody. They can also do more things to control people. So they can change policies, they can effectively shut down certain types of behaviors if that's what they choose to do, because the government and healthcare are one and the same, or they're a lot more one and the same than the United States, where we have healthcare is really a free enterprise system, still kind of matrixed in with government support. So you've got Medicaid and Medicare government, they tell you what to do and try to incentivize, you know, for public health. Then you've got private insurance, and they're now incentivizing for health because it benefits their bottom line, but there's no force above them unless the government makes a law or a rule that everybody has to do a certain thing. So our country is very matrixed around free choice and what the system wants to do versus what it really ought to do. And in socialized medicine, in countries that have healthcare systems run by the government, it's more blurred, it's more control, or it can be more controlling. Okay, so it's why we are. Okay, this is where our country is, and it keeps leaning more towards pervasive control as a general rule than individualism and I'll make my own choice up. Somewhere between those two is where we are. Okay. There are other partners. There are groups called non-governmental organizations. Have you ever heard the acronym NGOs? Okay, NGOs are just, it's probably referred to that way, but it's a lot of different things that are matrixed up under NGO. Professional member organizations, American Public Health Association, American Academy of Physicians Assistants, the group that you can be a part of. Associations related to a specific health concern like the American Cancer Society. They do a lot of things to help for screening and education. Organizations of citizens focused on health concerns like Americans for Non-Smokers' Rights. That group is one of the bigger groups to get shut down of smoking in public places. It wasn't just going to happen. You know, back in the 50s, smoking was pretty favorable, and it was kind of the cool thing to do. So smoking in public places was pretty common. I remember when I grew up it was really in the mid-60s that the smoking ban started to come out. They started putting labeling on cigarette packages. Before then, there was not an accepted link between smoking, cancer, and health risk. Then they put it on the package. That was a shocking government intrusion at the time. But I remember growing up, you go into a restaurant anywhere and smoking was just in the air. I mean, there's clouds of smoke everywhere you sit down. And it was just kind of like what you did. Get in a car with somebody smoking cigarettes. And you kind of get used to the smell of smoke, but I really am kind of glad it's gone because I didn't really like all that cloudy environment. And it was very socially acceptable to smoke. Y'all grown up when it wasn't socially acceptable generally to smoke all over the place, but it was. Y'all ever watch the old movies? I mean, it strikes me now, the movies in the 40s and 50s where everybody's smoking, and it's kind of cool. You rarely see that anymore unless it's like a certain group of people or a culture to kind of smoke and do. It's part of the persona of the folks. But back in the day, everybody smoked. In fact, it was kind of, very socially acceptable. Women got the right to smoke, and then it became cool for them, and then the stars all smoked. And if you were a cool person, you smoked, and if you didn't, you weren't. And now it's almost like you're smoking, what's wrong with you? So public health initiatives do work overall. And then you've got foundations that support health projects and influence public policy development, like Bill and Melinda Gates. They got more money than most nations in the world. Okay, so they provide money to help us learn things and educate. Here's a slide that looks at healthcare providers. This is what you are, and compared to public health. So what's the difference between what you do and public health? I don't think that you probably think you're not part of public health. I mean, I see myself as somebody who should advocate for good, healthy behaviors for the public at large, but we're really not that. We're not public health per se, but we're a partner to public health efforts. Here's the comparison. Public health has a population focus. You have an individual patient focus. Public health has a public health ethic. You have a personal service ethic. Okay, so you have a relationship with the patient based on they have a problem and you're there to assess and help them meet need. You can educate about behaviors that are not useful, but you have to do it within the context of maintaining a relationship so that you can continue to provide individual care. Public health is prevention or public health emphasis. Healthcare is diagnosis and treatment emphasis. Okay? Public health is joint laboratory and field involvement. So they're doing laboratory assessments, but of a larger group. You're doing a joint laboratory and patient involvement. Your lab is for a person, an individual. Okay, in public health, clinical sciences are peripheral to professional training. The training is more, and I'll let Ron talk about this here in just a minute, is much more about this public health approach. You know, you have to use the various sciences that comprise public health to do the public health thing. In healthcare, clinical sciences are essential to professional training. You need to operate within that individual, scientific basis for the individual patient. And then public health is a public sector basis, whereas healthcare is a private sector basis for the most part, even though there's still some public-private enmeshment in healthcare right now based on provider, insurance carrier. Okay. Other partners, as we said, media, employers, government agencies, academia, media, vehicle for public discourse, like we said, health education and promotion, health communication, social media is a catalyst for discussion. In fact, some things get so far down the pipe on a social media discussion that the government has to catch up with it, or it might be the thing that makes the government look at something. Just kind of an interesting way that things come to be. Employers can sponsor health insurance programs, wellness initiatives, healthy workplaces and communities. Government agencies like city planners, when you think about that, they're a partner, but, the government, started providing funds for handicap accessible sidewalks. Before you had those, people could fall. If you were barriers to get places. But that became a governmental standard for public buildings, and now private buildings do it because their insurance carriers will not insure them against liability unless they have, handicap accessible things or for older people to have access. So they do that. Education is helpful. How many of y'all had health in your curriculum in your school? How many had to take health? So those things, how does that happen? They don't teach it because they just thought it was fun. Somebody says at the state level that we're going to teach children this. Now there's lots of argument out there. We're going to teach sex education. We're going to teach you about birth control. Some parents don't want that. They think that's their job. Some citizens want that. They want it done by somebody else besides themselves. But all of those things being taught in public school are because a state mandates a curriculum, and the curriculum has to be figured out inside the individual school. So it's a partner, and they do things to help out. So now we know we teach a lot of stuff in school that, gosh, I remember when I was in school, if some of these topics were taught, it would be the end of the board of education. They would blow the place up. I mean, it's just stuff that's so common to us was just so shocking back then. Birth control and sex education. I remember when it first came online, it was like in the early 70s. When the sexual revolution happened in the 60s, and then people started to, how are we going to teach people? And I just remember all kinds of pushback from all kinds of people. Private schools popped up, we're going to teach what we want to teach, we don't want the public school teaching that. And it just kind of is all matrix like that now. There's just all kinds of ways to get education. Some in response to what the government wants to teach, and other parents want their children to learn a certain way. So there's just a lot of that going on. Academia does education training. They teach research. They do research. They help in public health initiatives. Okay, so here let's look at what these stakeholders do. What's the best vehicle for public discourse? Got to be the media. Health in all policies. Probably government. Anytime you get all, it's probably government. Education and training, duh. Wellness initiatives and benefits, got to be employers. Okay. Okay, final topic, determining and influencing the public's health. Okay, I talked to you earlier about health determinants. Here are 4 broad categories of health determinants. Genes and biology. Are you male or are you female? Do you have a certain ethnicity that predisposes to certain diseases? African Americans have a higher incidence of high blood pressure, that type of thing. Health behaviors, that's a health determinant. Do you choose to smoke? You eat high-fat foods? You don't exercise? Those things all fit in. Social or societal characteristics. What do people expect you to look like? What is the right body shape? Like I just talked about a little bit earlier. What is the educational system like? what does the culture value? Is it a tobacco valuing culture or not? There's a lot of things that happen in that vein. And then health services or medical care. Do you have access to it? Do you have insurance? Can you afford to have things done? Those things will play into your health. So not only what you are biologically and genetically, but what you choose to do, what society pushes that you do, and what access to health you have all determines how things turn out for you from a health perspective. Now look at this. What determines the health of the population? Medical care is less than 25%. Isn't it kind of shocking that the outcomes of health are 25% of it is responsible, is from the healthcare system itself, taking care of people. So you might do, you're responsible 1/4 of public health outcomes, but look at the rest of what goes into it. Health behaviors and social and societal characteristics almost together are almost 3/4. Genes and biology is about 5 to 10%. You know, we always say you are what's, you know, it's predetermined what will happen to you in life. You know, it's predetermined what your health is going to be. But when you look at the health outcomes that we see in the United States and the world right now, the largest determinant is the social characteristics and the ecology. Do you believe that? Do you think that's true, or does that kind of surprise you? It's a little bit surprising to me that it's not much more than that. That's pretty low. Does that discourage you? You kind of go like, well, you have to do what you do because we know healthcare makes a difference in people's lives and you can see things change. But if you're looking at the health of the population, when you stand back, okay, it's what you do in your room, that makes a difference. But then you have to stand back and look at the whole population, what's deciding what happens there. Behaviors and really social characteristics and ecology, that gets into living conditions, access, all those, safety, water, food. You know, we've seen food deserts, we've seen low access because of no insurance, low access because it's not believed to be necessary, a lot of things. So it's amazing that medical care, genes, and biology are a small percent of the whole thing that determines health of the population. So now you know why there's so much political activism about poverty. You know, if you're born in poverty, your life span is shorter, just right now. If you're born in Africa, you have a much higher chance of dying as a baby than you do in the United States. In the United States, actually, our death rate from of newborns is higher than most of the industrialized world. And you have to ask, why is that so? Mostly because of access, poverty, locations. You know, we don't have health providers everywhere. If you had them everywhere, people couldn't access them because of insurance limitations. So there are big things like that that have to be addressed to actually improve the quality of health overall. And our country tends not to want to address some of those things. Are, you know, pull yourself up by your bootstraps. If you don't have anything, it's your fault. You know, it's just some of these things, some of these beliefs out there. Okay, health impact pyramid. Okay, here this is more towards the individual. This is the wide population, so it moves up. The higher you are to the tip of the individual, the more likely counseling and education takes place. Then as you move down, medical care, then preventive medicine, healthy decisions are the default decision is healthy, and then socioeconomic factors. The more you move to the base of the pyramid, the more that a public health approach makes an impact. So if you're trying to get rid of poverty or large societal issues, public health will be involved to some extent. Now as you move up the pyramid toward the individual, there's an increasing individual effort needed. So you operate probably the top half of that pyramid, from preventive medicine and medical care to counseling and education. That's where you fit in. When you get down to the bottom about making healthy decisions by default or socioeconomic factors like poverty, those are more governmental, issues, public health issues that are bigger and more broad. let's see here. Here's some examples of activities that fall within these categories. Counseling education, that could be tobacco warning labels or promote quitting, medical care's treatment of heart disease, for example, preventive medicine, vaccinations, and cholesterol screening, making health decisions, the default seatbelt laws, smoking restrictions. Those are laws the government puts out to kind of lean people in the direction of a healthy behavior. So laws try to create default behaviors. How many of y'all would never start a car without fastening your seatbelt? I mean, pretty much we were raised that way for the most part. But why don't they make a car that won't start unless you have your seatbelt fastened? Probably because the auto industry doesn't want that. Probably somebody to rip the thing off. I mean, you know, so why do we not do that? Why do we not do some things that can make a big difference? Because you've got business interests that don't want that to happen. So that's where the rest of the world has a say about what happens to your healthier population. Okay. And then you get down to socioeconomic factors, poverty reduction, education. Those are bigger issues. If y'all have any ideas on poverty reduction, I think I'm all ears. You know, it's an almost insoluble problem in the world. It's always been there. Okay. 4 determinants of health. There it is, genes and biology, health behavior, social, societal characteristics, and health services or medical care. Okay. As you move up or down the health impact pyramid, the public health impact grows greater. It should be down as you go down the pyramid. And as you move up from the bottom, it is individual effort increases. So, just in review, we'll wrap up here pretty soon. Public health core sciences, again, surveillance, preventive effectiveness, epidemiology, laboratory, and informatics. None alone describes public health. All 5 operating together is what defines our public health issue. Those we'll let go by. We'll stop. Okay, there you got kind of your big overview for public health. I wanted to carve out a little time here. Reflect on that just a little bit. I'm going to ask Ron to talk a little about his experience in public health. I know we've got 2 others with public health backgrounds. You're educated, but you didn't practice. You interacted with it a little bit in your job. And then Sakaba done a little bit of stuff too, right? Okay. So, anybody have any views about public health, good, bad, or ugly? I'm just curious. Do you think you have a lot of responsibility to it?
Yeah, I mean, my major was epidemiology, but I never practiced as an epidemiologist. For one, it's a lot of work for very little pay, I think. But.
Yeah. And that's kind of the issue that's going on at the State Department of Health right now. A lot of things that should be done, a lot of things mandated to be done, not enough money to get it done, and I think there's a built-in frustration to it. Because it requires money, and it requires people. And you saw the paper this past weekend, 10% of the people are going to be laid off the Department of Health because their budget is completely blown up. And so all the people who don't really have benefits within the system are going to be scraped off. So what do you think that's going to do to public health efforts in Oklahoma in the next year? Well, you don't get rid of 10% of anybody's workforce and do more. I mean, it's just that, so to me, there's just a whole discouragement element moving through Oklahoma public health right now because of funding, underfunding, underappreciation, but more dictates on do this and do that. I think that's hard. Okay? Yeah.
I didn't exactly work in public health per se, like when I was with the schools, we kind of did different outreach with some of the public health, like the tobacco and things. But we would, we'd email every teacher to like come in, and we were going to do like nutrition courses and stuff like that. And with teachers being so low, there's no class time, so that nobody would even let us come in. So it kind of got discouraging because you're trying to prevent childhood obesity and stuff, but nobody will even let you come in to talk to students about it.
You know, and they've got this curriculum that they're trying to deliver, so it's just, you're eating up more time on something I think I've got to do. So that means that that organization didn't place a high value on it. They would probably tell you that they think it's all good, but within their time span, not good enough to take time. Yeah, Zane?
I really like how there's been a swing to emphasize more on prevention, because in the past, everybody would want a quick fix. You know, you go to the doctor and they're going to give you some type of medication, but it's not a miracle drug. So the consistency on starting with prevention early on, and kind of to go what Lauren was saying about education in schools, our population is so uneducated in great amounts that it's really hard to emphasize prevention if they're not getting it at all.
Yeah. You know, that is kind of a great irony. It's kind of strange. We now have the most interconnected planet that we've ever had in terms of getting information out. And ignorance on some of the most common topics is so great right now. And it's hard to figure. I have my own reasons about why I think that's true. You know, people tend to focus on what they want to focus on, and they can just get lots of it in a day. Because if you like sports, okay, you can be on your sites all day long, and it distracts from other things. If you like those things, you can look at it. But the other part of social media is that everything that's out there is not accurate, or there might be counter views that come out, and they seem to be everybody's liking this and liking that, and then people start reading that and they think, well, that's really the way it is, but it's really not the way it is at all. So, but because people don't read and think for themselves and study, you know, all the issues out there, they just believe the first blurb that comes at them, and so you are having to counteract mass-produced ignorance. I mean, it's mass-exported ignorance, or lack of awareness, or whatever you want to call it. And it should be an age where it's much better done. Yeah.
The other morning I was watching Fox News, and they were hailing President Trump because he had made it more lenient for the school meal regulations that Michelle Obama had put into place. Mm-hmm. But all the stuff that Fox was reporting, none of those were even included in the meal regulations to begin with. So they were saying, you know, like, he took away sodium requirements. Well, that already like been a pause on that from the beginning, and they were like, now there's flavored milk. Well, that was always allowed the whole time. So it's like they were hailing the changes that took place, but I was sitting there going, none of that stuff even was an issue at the time.
And it's a good point you raised, because what you see in the media now is it reports or spins for its own narrative for a political point of view. And if you don't watch a lot of stuff and you read up underneath that, no channel can tell you what's really going on. You would miss it. So, but that's part of what is educating the world.
I think like what she was trying to do is a good idea for the public health, like trying to get kids to eat healthier. But I know from like one of my old teammates started a program because in a lot of the poorer areas, with her reducing calories so much, those who played like sports after hours, like they didn't have enough calories to get them through to 5 o'clock practice, and so like she had to start a program to like get
supplement
food out to those students who played sports. So I mean, I think it was a really good idea, but I think in certain communities it actually hurt them because there wasn't enough food for those people who couldn't afford it.
And the issues that are out there are multi-layered and complex. We tend to operate in little sound bites of this is what the issue is, and you would have to say this is what the issue is in this community. This is what this issue is in this community. And so there are no blanket fixes that make sense for everybody, and so that's kind of showing up. Ask Ron to talk to us a little bit about his experience in public health. You can be as detailed or as generous as you want to be, but just to get an odd perspective, because he actually practiced as a public health practitioner for a while, so he's got something to tell us that I can't communicate the same way.
So just to set the stage here, we have like one of the best educators in our program that just presented stuff from the CDC to you, so I'm not sure what I'm supposed to add here to that.
But your perspective of being in public health, I think, is probably the most helpful.
Yeah, I mean, overall, I mean, kind of like what Zane was touching on, the prevention, I mean, a lot of that coming into your clinical care has been, public health's always been about moving the bar upstream. How can you get further upstream? Like, I've got people coming in for lung cancer, so how can I stop that? And then you start thinking about smoking, you start thinking about other things that affect that. So that's kind of the nature of the beast. But the big thing that I've talked to Dr. Britton about that is touched on here, but it's hard to get out of these things. And I talked to Zane actually at lunch about this. You go through these and you know that government's involved, but until you actually work in it, it's kind of hard to understand how much that impacts your life or how much that impacts what you can get done. For instance, you know, you have some things that are safe. I was lucky at my last job that I was actually in cancer epidemiology, which was fairly safe because cancer's a big problem and a lot of people care about cancer. So there's a lot of government funds that go to that. And that's kind of another whole deal is, you know, as healthcare providers, what we're going into, we have insurance and individual payers that are going to be supporting us and providing that money. In public health, you're working with somebody else's money. You're working with public funds. So public funds aren't stable. With something like cancer, heart disease, something like that, they're stable. Whereas some of the people that get tied in, like the kiss of death would be to get put on something. And this is where all the young guys get put on something like Zika or Ebola or something like that because that's the flavor of the day. So, I mean, it's nice. I mean, there's a media. So what ends up happening there, like we had a Zika thing in Arkansas when I was there, and what was interesting was that we knew, okay, this is coming, and then all of a sudden somebody came back from Brazil, they went to our public health laboratory, they were diagnosed, it's all over the news, and then we get senators and the governor calling us because all of a sudden voters care, and then so we're going to divert funds. So what happens is we have, I was even involved with this because our maternal and child health epidemiologist is now working on Zika. So me, I'm the cancer epidemiologist, all of a sudden now I'm working on preterm births and things like that. So, so it's just kind of interesting how fast things can change and how things are unstable. The other thing that's interesting is you might, like if you're an epidemiologist assigned to like Michelle Obama's thing, right, with the school, and you're evaluating that, because epidemiologists, like on the one slide, they're pretty much tied into all of those things. Anything that involves numbers, that's what ends up happening as funding gets cut. Epidemiologists, whether it's studying diseases or not, we get pulled into anything that involves numbers. So, you know, we might be working on that, and that seems like a good thing at the time, working on Michelle Obama's initiatives in the schools and how is that working and evaluating that. But your job's only as safe as the administration. So then when the Trump administration comes in, you either get re-diverted or you're one of that 10% that gets cut.
Yeah.
So it's just kind of, I don't know, I just was trying to give some examples of how unstable that can be and what that turns into as you guys get out there too. Another thing is as a provider, you're going to have to work with public health at some point in some capacity. And if you ever do have to work with any of the government entities that have public health guys, I always either saw the old providers that had been in the system for a while and they knew kind of how everything rotates around and everything. And so when things fell through, they never got mad. Or I had the young providers that thought we were a bunch of flakes. Because what ends up happening, you might be working on a project, you might be really involved in it, and then it just falls through. And it's not because the people, in general, the people at the health departments that I've always met, they're all about preventing disease. They want the best outcomes for the world. I mean, they're wanting to go out there and change the world, but they're limited by their funds. So if you're ever working with any of those guys and they just disappear on you, they might not be there anymore. Trump administration might have gotten fired or something. Or whoever the next president is. It's not just Trump. It just changes. Interest changes.
You know, it's interesting. It's the impact of government, where you have government that's taken over by one party or another, or one interest or other. It's just the way it is. When I worked in the VA, that is the best picture we have right now of what government-run healthcare would be like, because it's a massive system. It's connected with computers. There are policies they come down as national policies. And a lot of good stuff gets done. I really enjoyed what we did because I thought we made a lot of difference, but there was an equal level of frustration that went along, because if politics came up, you might be directed and diverted into one area where you get all excited, And my nature is I want to do it right, so we're going to get in there and do it right. And you might get deep into it and you begin to start to see positive results. And then somebody comes along and says, no, we're not going to do that, we're going to go over here. I mean, just like complete shutdown. So you have to have this mentality that, okay, the big things will probably keep running, the very big things, but the focus can shift from one year to the next. And like right now in the VA, the big thing was waiting time. You know, waiting time to see a primary care provider. And that got national press. And here in Oklahoma City, they got incinerated down there. Did y'all look at the newspapers about here? People who didn't get care, surgeries that didn't go well, and deaths that resulted from that. So they kind of cleaned house, brought in new directors, and now they can report wait times of a certain level and more safety procedures in place. But all of those things take time and money and focus. And if you get the money and you're given the time and you have the focus, it can change to another set of money, time, and focus. So you just have to play the game that you're in the best you can, but don't get too married to what you're doing because it may not hold up. And I think that's the frustration up underneath public initiatives, because this matrix, you see the stakeholders, the government's always part of it. And I'm not anti-government by any means, but it's just that what runs government, it can be taken over by one viewpoint or another viewpoint, and then it just goes that way for a while.
To kind of give you an example of what you're talking about in public health too is, you know, you can't get the money without evidence. So now everybody that's providing funds, whether it's an NGO or a government entity, they want evidence that it's going to work. So they might give you a little bit of money to run a pilot, and so then you start, you know, you might stay, and a lot of times what's frustrating, a lot of times it's something you know is going to work. So you might think, okay, if I put new sidewalks in this area, people can walk, it's going to be safer, it's going to help healthcare. So you put the proposal out there, well, they want to know where the evidence is. So they give you get a little bit of money spread together to try to run this little pilot program, and you spend 3 or 4 years getting this evidence that putting sidewalks in a new community is going to help people be more active. And then by that time, something shifted, and that all gets, nobody cares anymore, so that all gets scrapped. So it's kind of a lot of times in public health, you're spinning your wheels, I guess. It's kind of the typical way.
Now, but that all this being said, we're kind of giving somewhat the negative side of things. There are many positive things that do happen that are fairly constant, and there is important surveillance. But this is like everything in healthcare. This is no different than anything else in healthcare. When you have seemingly unlimited needs and you have a limited resource for payment and even limited numbers of providers, you can't solve the whole problem, but you make your piece of the pie. You do your part of the contribution. So y'all will be dealing with that throughout life. It's pretty much normal. It's kind of the way it is. And I always look at what I do as I'm making a difference, and I'm going to do what I can do that's supported right now. And that is better than if you didn't do anything. Way better. Okay. Any other questions about public health or that system?